Pleasure of introducing the next three speakers. Dr. Justin Otis is a neuropsychiatrist and new to the Northern Light Health System. He sees patients and teaches residents at the Mood and Memory Clinic at Northern Light Acadia in Bangor. His primary training was in psychiatry at the University of Arizona, where he also completed a 2-year elective in integrative medicine at the Arizona Center for Integrative Medicine. Dr. Otis then completed a behavioral neurology and neuropsychiatry fellowship at the University of Colorado and received training in traumatic brain injury rehabilitation at the Marcus Institute for Brain Health. He led an interdisciplinary dementia clinic at a large hospital system in Wisconsin prior to joining the Mood and Memory Clinic at Bangor in 2023. He leads the neuroscience curriculum at the Northern Light Acadia Hospital New Psychiatry Residency. His areas of clinical expertise include neuroimaging, traumatic brain injury, neurodegenerative dementia, with a movement disorder such as dementia with Lewy body, Huntington's, frontotemporal lobular degeneration. Next, I have the pleasure of introducing Lori Towne. Lori serves as the medical staff president for Northern Light Mayo Hospital and the primary care service line and clinical lead for both Northern Light Mayo and C.A. Dean hospitals, both located in Piscataquis County, the oldest based on the age of the state. In addition to this, she serves on the medical advisory board for the state of Maine. She's president for the Maine Nurse Practitioner Association and also serves as the board member for the Hanley Center. Lori is on the Healthcare Advisory Council for the Maine Council on Aging, and currently she is working part-time in a 12-month HRSA grant-funded role in the Rural Dementia Training Project as primary care liaison and faculty. Lori lives in Dover-Foxcroft with her husband and is originally from Milo. Dr. Cliff Singer is a psychiatrist and geriatrician coming from Maine in 2010 after many years at Oregon Health and Science University and the University of Vermont. He is now the chief of the Center for Geriatric, Cognitive, and Mental Health at Northern Light Acadia in Bangor, a research professor at the University of Maine. He was the founding president of the Oregon Geriatric Society and the past president of the Maine Dorrigo Geriatric Society. He received awards for research and clinical work with older adults in both Oregon and Maine, and has been voted by national peers to be included in the Best Doctors in America In 2023, the Maine Council on Aging gave him their annual Trailblazer Award for innovations in clinical care and research in dementia. If we could give them a warm welcome to the podium.
Thank you. Hi, everybody. Been a few years since I've been here, but I remember you all. I'm Cliff Singer. I'm the token older adult in our geriatrics program. It's part of our diversity initiative. And Lori's only going to let me do one slide.
Acting Adam.
Which is my prerogative to act then. We don't have any disclosures other than that I'm part of the diversity program. We all received some support from the HRSA Maine Rural Dementia Training Project, and that's really all I'm going to tell you about today before we go into our real content. But the learning objectives involve being familiar with cognitive screening and cognitive assessment instruments, having some familiarity with the changing landscape of pathologic confirmation of neurodegenerative diseases, especially Alzheimer's disease, through fluid biomarkers. And then discussing what the criteria might be for a referral to our clinic, which is the Mood and Memory Clinic. And by the way, we're renamed. Our center is renamed. It was the Center for Geriatric, Cognitive, and Mental Health, which is too long. So we're now the Northern Light Memory and Aging. That's it. Northern Light Memory and Aging. We wanted it to be the Memory and Aging Institute, but we're not allowed to use that unless we get a big donor. So if any of you are feeling generous today and want to have an institute named after you, come talk to us. So the Maine Rural Dementia Training Grant was a congressionally mandated grant that we received with the support of Senator Collins to improve dementia care, not just in our system, in the Northern Light system, but really throughout Maine. And there are three primary objectives. The first is to improve dementia capability, knowledge, and confidence in caring for people with dementia. And that's one of the reasons why we're here today, is to fulfill that criteria. But there are many other initiatives within this. And we have a table there, and there are some flyers on your tables that describe some of the benefits that this wonderful project is bringing to us, including an embedded clinical dementia care pathway. Lori will talk more about that. A monthly case conference for your challenging cases for people with cognitive impairment and dementia. And we have two conferences coming up, other live conferences focused on dementia. One is part of the University of New England annual geriatrics conference. Is in Bar Harbor, May 21 and 22, just coming up in a few weeks. That's a wonderful conference in its own right, but we have on Thursday, May 22nd, a whole day of a core curriculum in diagnosing and treating people with dementia. And then a few weeks later, June 13th, at the University of Maine, we have a case-based learning conference where we do special topics in dementia care and then talk about cases. These will be wonderful cases, wonderful conferences that will augment what you're going to hear today. The second objective of the grant is to train 2 nurse practitioners through a one-year neuropsychiatry residency, and our nurse practitioner neuropsychiatry residents are right over there, Kayla and Carrie. Kayla's from Maine. She was here, but Carrie's come all the way from Minnesota to do this residency. And so our job is to convince her to stay in Maine. So you do your share of, you talk to her, okay? Tell her to stay. The third part of the grant is to create a statewide consortium of neuroscientists and clinical dementia specialists to guide us through this new age of precision medicine for Alzheimer's disease. The science is rapidly evolving. Dr. Otis will talk some about that. And I think all of us need a place to go to present cases and know where they fit into the landscape of rapid evolving diagnosis and treatment, specialized disease modifying treatment, which is here for Alzheimer's disease now and soon will be here for other neurodegenerative diseases too, like Parkinson's disease, Lewy body, ALS, etc. Okay, that's all Lori will let me do, as I said. Here she comes.
Trouble. Hi, everyone. So as Dr. Singer outlined about the project, my part of the project has been really more focused on primary care and helping to support that objective and help be part of a team-based approach for developing a care pathway and then doing education with the primary care providers. And throughout the state of Maine, we're Northern Light, but the case conferences, everything we've talked about, that's open to all. So we know that primary care providers are often the first point of contact for patients and loved ones when there's a concern around cognitive impairment or dementia. Initial assessments and referrals are always started by primary care. I shouldn't say always, but very often by primary care. And those of us who are out in rural communities or not in doing primary care, we also, recognize that it's really hard. It's hard to know what to do. It's a changing landscape, and we know access is challenging. So with this, we talked about that primary care providers really need to have more resources, more education, and more confidence to start those evaluations and the screening process. So as Dr. Singer indicated, for the dementia care curricula and resources for primary care, doing the embedded clinical pathway or care pathway for people who work at Northern Light in the electronic health record. The website, Dr. Otis, especially, this has been a labor of love for Dr. Otis and the team and Dr. Hallnagel. So the website is going to be a great resource for people. There's going to be videos on there about 1-minute neuro exams. There's going to be resources around doing the evaluation, what other resources you might have, the referral process. So that's been a work in progress, but coming. The monthly case conferences, like Dr. Singer indicated, that is free 1-hour CME every month, 4th Wednesday, alternating 7 a.m. to 8 a.m. with noon to 1. And we've got registration information on that on the tables. And then the conferences, I won't go into much more detail about that. And let's go right here. And so here are the case conferences. We already talked about that. You've got information there. So then the clinical pathway development. So with this, we did collaboration with an interdisciplinary team across the state, including, we know Dr. Madden, Dr. Amy Madden has spoken here, Dr. Rebecca Spear. So really trying to get statewide on the same page with this approach and evaluation. Goals around consistent screening, evaluation. All right, and then dementia is preventable. So these two slides or these two diagrams are from the Lancet. First one is from 2020, second one's from 2024. So this is something as primary care providers and as APRNs, as nurse practitioners, one of our jobs is to educate and support. So we have already had people coming up to us here at the conference saying, oh my gosh, you know, my mom, my dad, my grandfather was early onset and I'm really scared and I'm not sure, you know, what can I be doing? And a lot of us have different varying knowledge with this, but we know that there are some components that are protective and some risk factors that are modifiable potentially. So the diagram on the left, we talk about 12 risk factors. So physical inactivity, smoking, excessive alcohol consumption, air pollution, head injuries, infrequent social contact. We know loneliness and social isolation is an independent risk factor for early mortality in general and comorbidity. Less education, obesity, hypertension, diabetes, depression that's either undiagnosed or undertreated, and hearing impairment. So the diagram on the right is the more updated one from the Lancet, and that gives you a better visual on where those risk factors really come into play at stage of life. I really like this next diagram because I think when we're doing that education with our patients and even for ourselves and talking about these risk factors and why these make a difference, why controlling diabetes and cholesterol and hypertension, what part of the brain is this really making a difference in, and looking at the decreasing vascular damage, reducing the dementia and neuropathology, reduce stress and inflammation, build cognitive brain reserve. So this algorithm is our care pathway, and this is something we've continued to modify. On your tables, you're going to see a dementia care pathway for the Northern Light Health System. So Dr. Otis very kindly and a lot of time, a lot of energy put into this to really give us more of a diagram in a readable format. Algorithms are great, we like those, but sometimes you just want something that you can really go down through and almost check off. And this will help you organize your thoughts a little bit when you're doing these evaluations. So who needs to be screened? The annual wellness visit, the Medicare annual wellness visit is an ideal opportunity to do these screenings. If you have clinical suspicion, you know, you've got your patient coming in, you're thinking, boy, you know, they just always seem to, you know, running out of their meds or stopping this and something just doesn't seem right. I really think I should screen this person. Or patient and family concerns, you know, when they come, they're like, you know, I'm a little bit worried about dad, you know, he ran into the garage again, you know, you've just got these different things going on and not sure what's going on. Different screening tools out there. I think everybody has their favorite. We know, I know the VA, I think we've got some VA folks in here, use the slums. For the purposes of our care pathway, we're talking about the mini cog, the MOCA, and the 88. So for those of you who aren't familiar with the 88, that's an 8-item informant interview to differentiate aging and dementia. If the informant can't come to the visit, call them up. I've asked my medical assistant to do that. I think everybody else is pretty familiar with Mini-Cog and MoCA, the Montreal Cognitive Assessment. So what we are recommending, because of course, especially in primary care, we don't have a lot of time. So you get that Mini-Cog, it's not great. You get the 88, and then you go into the MoCA. The MoCA will give you more information. And for those of you who aren't familiar with the Mini-Cog, there's just a slide showing that. And then this is the 88, which my medical assistant loves this. She's doing 88s on everybody now. Actually, let me back up. So for interpretation, 0 to 1 is going to be normal cognition. 2 or greater, you're thinking about there might be some cognitive impairment. The Montreal Cognitive Assessment, normal is 26 or above. You start thinking about mild cognitive impairment, 18 to 25, moderate impairment, 10 to 17, severe, 0 to 9. And you see, you can add on semantic fluency, and that's the 1-minute animal naming. And then the result should be greater than the phonemic fluency, sorry. So obtaining a good history, we know that this is another component that's important with all of our patients in any approach. I had a physician that I precepted with years ago in my training, and he said, if you listen to your patient, they will tell you what's wrong. So really getting that good history. The physical exam, again, a good physical exam. And Dr. Otis took a minute to perfect this a little bit for us, and it's in the slides. So thinking about what's mental status, ocular exam, cranial nerves, reflexes, strength, sensory, movement. What's that gait? Is there an arm swing or not? Depression screening. So starting with the PHQ-2, it's fine. You don't worry. If you go on to the PHQ-9. And so I had found this diagram through the APA and gave kind of a breakdown of what do you do? And I think that's a whole separate talk. So I won't go into that. That's not my area of expertise. Medication review. What are patients taking over the counter? What are we prescribing to them? We know a lot of these patients are comorbid. There's other specialists involved. So really taking a look at those meds, have them bring in the grocery bag with their medications. Use your clinical pharmacist if you're fortunate enough to have one. I've pulled in our clinical pharmacist on a variety of cases. Do they have a high anticholinergic burden? Antidopaminergic. I can never say that word. Thank you. I have to say it slow, not like a New Yorker. Sedatives, hypnotics. So, and again, consider that clinical pharmacist consult. Consider deprescribing, and that's something I think that we're always a little nervous doing, especially when there's other specialists involved. Pick up the phone, talk to your psych NP, talk to other people. Sleep disorder screening. So I don't know if people are running into this in other organizations, but Northern Light, they're now really pushing towards the Berlin. I've always done the Epworth Sleepiness Scale. Stop Bang is another one. And then looking at sleep-related breathing disorder or REM sleep disorder. Are they acting out their dreams? Are they, running in bed? Are they, clawing, hitting, what's happening at night? What's happening with these people? Is there sleep deprivation? Do they have good sleep quality? And then working our way down through that care pathway, ruling out secondary causes, get that basic lab panel, get the CBC, CMP, TSH reflux to T4, B12, and with a reflex MMA, because we know we can get those low normal B12s, and hard to differentiate, is that a true deficiency or not? And if there's risk factors present, thinking about the HIV testing or an RPR, Cedrate, CRP, maybe whole blood thiamine. And then neuroimaging, I'm going to hand this over to Dr. Otis. I'm sorry, I know I talked fast, but I really want to hear what Dr. Otis has to say. And I think you do too, and have time for questions. So I'll have you come on up.
Thank you, Lori. Thanks all of you for having us here. I just looked up on ChatGPT. I was curious as I was sitting there that, at least according to that, there are more primary care nurse practitioners in Maine than there are physicians. So this is the backbone of the workforce in primary care. So thank you all for the work that you do. I'm guessing that every hand would go up in this room if we asked if you've seen someone with dementia. Again, this is in the hospital setting, in the outpatient setting. This is a very common problem. We live in the oldest state in the country. And so our goal really is to enhance all of our abilities to evaluate and manage these folks. Neuroimaging is an important component of evaluating for dementia. Dementia, that term implies progression over time, in which case there has to be neurodegeneration, which means the brain has to degenerate. And so we should look at that thing and to see, does that show any signs of degeneration? Well, this is a tricky thing because often you get your radiology reports and it might mention something like there's generalized atrophy commensurate for age. And it gets a little tricky for primary care providers not being able to dig into that further, but it is an important stepping stone and a piece that helps us integrate with specialists who have the ability to look into these things a bit further. And we'll work through that also with our case conferences. We'll review imaging. If any of you like to bring a case to us, we can show what we see on the specialist side, because neuroimaging really is one of the cornerstones of these treatments, right? Or these evaluations. The history is everything. The exam is everything. The imaging is, and biomarkers, and all of these things should point towards the same underlying etiology. And that's when we have that well-rounded approach in addition to the cognitive assessment. So a non-contrast brain MRI is the standard of care. There are many things you can't see on CT that are going to contribute to cognitive decline. A good example being cerebral amyloid angiopathy, which is quite common. Of course, using your best clinical judgment, if something is acute and there's a focal finding, we need to get imaging to evaluate that, especially with acute or subacute onset. Happy to talk about that further, but I'm going to keep moving. So there's lots of biomarkers and imaging modalities we use in the specialty setting. MRI is pretty standard as part of a primary care-based workup for dementia. We order additional things like an FDG PET scan. This looks at glucose metabolism and which areas of the brain are still functioning and taking up glucose and have an active metabolic profile. So these are used. It helps differentiate Alzheimer's disease from some other dementias. There's Medicare approval for the indication of differentiating Alzheimer's disease from frontotemporal dementia. Coverage is pretty good for that. We order these regularly. More difficult to get is an amyloid PET, and this is an extremely sensitive test to detect amyloid plaque within the brain. These are hard to get in Maine. We have a few institutions that do this currently. We have in a research capacity previously. We're getting that back up clinically, but I know Maine Health does and Maine General are able to get those. For our folks that were worried about Parkinsonism and trying to figure out the cause, who see somebody in clinic and they're on aripiprazole and they're shuffling and they have tremor, is it the aripiprazole or do they have Parkinson's? And this is a test that helps us differentiate the two, drug-induced from some other primary cause of Parkinson's. And we have new Alzheimer's disease biomarkers, which I think is a hot topic to discuss today. We're utilizing those regularly. We get lots of questions from primary care about should we be doing that in that setting? And I think those are things to discuss as well. Like Dr. Singer mentioned, we are entering the era of precision medicine for dementia care. And so we're talking about genotyping people and getting biomarker confirmation, and those things actually informing which drug and if you get different drugs. And so we're answering sort of what has already built out in the cancer world with very specific gene-targeted or gene-informed interventions. So we'll talk about that some more. This is a tricky one. These are brand new plasma biomarkers for Alzheimer's disease. There is not currently any guidelines that support the use of these in primary care. Those are in development. But I know from our organization that the labs are pushing them. We had Quest show up on our clinic doorsteps and are bringing this, we have this new test and selling it to primary care. And we had a lot of resistance. Like, we don't know how to interpret this. We're not comfortable with this. So we tried to incorporate this into our algorithms, and we'll kind of describe some of these things. So kind conceptually, a couple things I want to reinforce. All right, Alzheimer's disease is not the same thing as Alzheimer's dementia. You can have Alzheimer's disease and not have dementia because your cognitive impairment is not severe enough or even present to cause functional decline. Right? You can have Alzheimer's disease, pathological changes in your brain, and have no cognitive impairment. Alzheimer's is a 30-year disease, the first half of which is pre-symptomatic. And so we can get tests on people. You can do an amyloid PET on asymptomatic people and find Alzheimer's in their brain, but that may not be the cause of their cognitive impairment. That's why going through a well-rounded workup sequentially, like we talked about, is really important to figure out other contributing causes. You may have someone in your clinic who's cognitively impaired and has Alzheimer's biomarkers become positive, and the Alzheimer's has nothing to do with their cognitive impairment. So important to understand that distinction between presence pathologically and clinically significant or clinically caused symptoms. So again, a lot of these biomarkers, depending on which ones, that can be positive 8 to 20 years prior to the onset of cognitive impairment, depending on which one. And so we have to consider those things with discretion. The most common one you're going to hear about is plasma p-tau217. It's a tau marker. It's available in plasma. It correlates really well with the amyloid PET scan positivity, which is very sensitive. The nice thing about this one is it also correlates with disease severity and damage and neurodegeneration. So higher levels mean more damage, and that can actually give you some sense. These low normal, these borderline levels are interpreted with much more caution. This just came up actually a few months ago that CKD modifies the levels of these depending on which lab runs the test by anywhere up to 55%. So I know for the Quest lab, our cutoff is like 0.15, and if they've got CKD and their cutoff and their levels 0.25, that may not be a positive test. So these aren't perfect like any other test. We advise using this very cautiously at provider discretion. People who may have a lot of experience with dementia, have close ties with a specialty clinic to relay questions back and forth. But folks who are younger, who present with mild cognitive impairment or mild dementia, are potentially candidates for anti-amyloid therapy. So this is something to consider in the context of them looking like Alzheimer's disease, right? These are people with progressive short-term memory loss, disorientation. They have low semantic fluency, like on the animal naming task that Laura described. They've got visual, spatial, and executive dysfunction. There's often a prodromal depression and anxiety syndrome before the onset of cognitive issues. And usually they have impaired insight, right? It's their daughter bringing them in, and they don't know why they're there. And judgment as well, vulnerability to scams and those things. If that's what their story looks like, and they're in this sort of demographic age-wise, I think that's reasonable to order that test. Again, if you have a relationship with some sort of specialty clinic, when there's questions about how to interpret these things. So this is not part of guidelines right now. This is what we sort of came up with as a team to provide guidance to the folks in our healthcare system in the primary care setting. And that's a work in progress. You'll hear more, especially in the next year or two, from organizations providing formal guidelines. So this is where we're starting for now. I think when to refer and where to refer to is a really common question, right? From our standpoint as the specialists, there are many cases that are appropriate to be managed in the primary care setting. When we're dealing with routine late onset Alzheimer's disease or vascular dementia in some of our older folks, and they've got adequate support, right? They have a living environment, they have attentive children that are providing care, or that infrastructure is there. If there are not significant neuropsychiatric symptoms or other neurological comorbidities, again, those folks can be managed in that setting. And then the really medically ill folks, I think there's much, much less for us to do as specialists. If someone has cirrhosis and CKD and they've had 3 strokes and they have CHF, we're not going to be able to do much. Even if you do get a diagnosis, we're not going to put them on. Even the acetylcholinesterase inhibitors are unsafe in a lot of those folks. So these are folks that I think were best managed in the primary care setting, of course, with caveats. We advocate, I think I'm going to go here first and then go back. Dementia care is a team. It takes a village. And there are so many different specialists with different backgrounds that we should rely on collaboratively to provide the evaluation and the treatment and the care for these folks. And so utilize your resources, right? You may have good access to some of these specialties and not others, but we can work together to help care for these folks. So in that sense, utilize speech therapy and occupational therapy. They have skills and formal training in evaluating people with cognitive disorders. That can be done in the home setting, in the setting of occupational therapy. We frequently use that. And then, we're building out resources to ask questions, building out this case conference so that if you have a question, you want to present a case, everyone benefits from that learning. So we're building out that infrastructure as well. So we met with a panel of folks across our whole organization with representations from our clinic, neurology, neuropsychology, primary care, and kind of agreed, like, at least in our system, this is who we want to see. A neuropsychologist, for those who may not be familiar, is a trained psychologist, usually a PhD or PsyD. Then they had a postdoctoral fellowship in neuropsychology. They're doing extensive cognitive and neurobehavioral evaluations for folks and comparing to statistical norms, adjusting for age and education and sex, and really figuring out what is the primary issue that a person is having cognitively. Is it executive function or memory retrieval? Because all the patients just say my memory's bad, even if it's not memory, it could be language, right? And so they're providing these very detailed evaluations. They really, it's appropriate to consider neuropsychology if someone has progressive decline in anything, in any cognitive domain. When multiple causes are suspected, it's hard to parse out what's due to what, and they're very good at that as well. Anybody with a high or low level of educational achievement and IQ, the screener tests like we do, like the MOCA and the MMSE, lose validity. And so people with, an MD and a PhD do a MOCA and it's 30, they could have dementia, right, and still be doing okay on a screener. And the opposite is also true. Somebody's baseline might be a 14 on the MOCA, and they've not had any decline. So you have to interpret the test results in the context of the clinical history. So when that's the case and you're trying to figure out, is this new? Is there something going on? Does it match with what their baseline is? Neuropsychology is really good at that. Recommendations on functioning too. If you question their driving, if they are still working, if you question their decision-making capacity, they're very helpful in aiding those things as well. And then lastly, we all run into this is in the case of especially Alzheimer's disease, insight is impaired. And it's often the family dragging them there to the appointment, right? And they need the evaluation to know how to support their loved one, how to get the treatment, even though the patient themselves doesn't want to be there. Neuropsychologists have excellent training in managing those dynamics, as specialists do in that setting too. So those are folks to consider a neuropsychology referral. The neurology folks, sometimes specialist dementia care occurs in the setting of neurology. In our case, we're housed at Acadia Hospital in the setting of psychiatry. So this may differ a little bit from institution to institution. In general, you're always going to want to have a neurologist involved if you have something sudden onset. Any focal findings that had not previously been documented. Anything rapidly progressive is worth a phone call. If someone's going from normal to meeting criteria for dementia in less than 6 months, then I want to hear about it. Anything with epilepsy, our movement disorder neurologists want to see folks when that's involved. Our neuromuscular neurologists, if there's any suspicion of ALS as part of their dementia. Frontotemporal dementia and ALS have about a 40% overlap. And then vascular lesions. If we find a stroke that you didn't know that you had, then there's a whole extra workup associated with that. In our clinic in particular, we kind of see everything, so both of the prior slides, practically speaking, often apply to us, but we really would want to see the early onset folks when it's atypical, is it primarily language or just visual? Anything with significant neuropsychiatric symptoms, delusions, hallucinations, personality changes, psychosis, and those require a much more detailed kind of neurobehavioral evaluation that I think we're well equipped to do. A dementia specialist should be involved anytime there's a suspected genetic cause where half or more of the family members are affected by some sort of degenerative condition, and the flavors can vary within families, and siblings with the same mutation can have different clinical presentations. So we have clinical trials going on for Alzheimer's disease. Dr. Singer leads up our research program, and so those are folks we take as well. And then with these new drugs, and I'm talking about those in a moment, if you have Alzheimer's disease, someone's the appropriate age, considering these more aggressive interventions with the new anti-amyloid therapies. So these are the folks that we really want to see at our clinic as well. And let's talk about, I think the new elephant in the room is anti-amyloid therapy, right? I'm sure we've heard about these. I'm sure there's been some marketing or TV commercials or whatever. There have been many, many failed trials for drugs in this class. There's been a lot of controversy over them, especially with the aducanumab controversy, which came out during COVID. But these two new drugs, these studies are much better designed. They're much more effective at clearing amyloid from the brain, and there is positive data. And in contrast to the medications existing on the market, like our acetylcholinesterase inhibitors, instead of just holding symptoms steady for a period of time to improve functioning earlier in the disease, which is what the medicines really do, these actually slow down the rate of decline. Depending on which metric you're using, the primary or secondary endpoints in the studies varied a little bit. Some were better, some are worse in comparing the two. But we're talking in a 25 to 35% reduction in decline, depending on the metric that you're using over a study period of 18 months. The drugs are comparable in many ways, but there are some key differences. So lecanemab or Leqembi was approved earlier, and donanemab or Kisunla just came out more recently. The age demographic is similar. We're looking at patients with mild cognitive impairment, so they can still function independently, or mild dementia, doing well with a bit of support. Since these are still pretty new and there needs to be more data, patients have to actually be enrolled in a registry, which functions like a research trial to be even eligible to get them. So this is not something we can just order from any provider. You have to have a specialty center who has research protocols and can follow those procedures. They're expensive, like any infusion for any drug is, but not that big of a cost difference between the two. One key point that separates them is duration of treatment. Lecanemab, the study was 18 months and people continued on it through that whole time. And there's question of whether that is needed long-term after 18 months and whether that would be covered or not. We're still sorting that out. In donanemab or Kisunla, there was a follow-up amyloid PET scan to see, did amyloid get cleared from the brain? And folks that we had adequate clearance, they trialed stopping the treatment. And so people could stop the drug as early as 12 months if they had full clearance and still maintain that clinical benefit. There's a lot of monitoring. I don't know if there's a term they used, amyloid-related imaging abnormalities, to make it sound kind of nice, like which means bleeds and swelling in the brain. I thought that was comical when that came out. But when you start these drugs, you're physically removing amyloid plaque from the brain. So you have a risk of microhemorrhages, particularly if they have comorbid cerebral amyloid angiopathy that you didn't know about, but also edema. So we have to do MRIs, lots of them. For donanemab, there are more, it's more frequent. There is a difference in terms of side effects or reactions. Infusion reactions are more common with lecanemab, less common with donanemab. But the incidence of ARIA, of edema or hemorrhages, is different between the two, or donanemab has a higher risk of those side effects, including symptomatic ones, which are headaches, dizziness, confusion, delirium, even in some severe cases. So advantage of donanemab, it's once monthly versus every 2 weeks. So logistics. Which is reversed. Oh yeah. Sorry about that. Thank you, Cliff. Treatment schedule should be reversed. It's monthly for donanemab, every 2 weeks for lecanemab. And so there is a difference between those. I don't think I mentioned earlier, we test ApoE genes. So you could do that in plasma. And some of you may remember the ApoE genotype impacts risk for Alzheimer's disease. If you have the ApoE4 allele, your risk of Alzheimer's disease is 4-fold increase compared to the general population. If you have 2 4s, it's 12-fold. And that informs our, counseling with families and informs their risk. Our APOE4/4 families, half or more of them have Alzheimer's disease. But it also informs treatment. And so the folks in these trials who had an APOE4 allele got less benefit and they had more incidence of ARIA, both of them, to where actually a lot of centers like ours won't treat folks with 2 4s because it's too risky and their benefit really is not well supported by the data. So, and also because there's a difference in ARIA between the drugs, folks who may have a single APOE4, it may be a consideration in choosing one drug versus the other. These are all specialist decisions, but just to know, for all of you to know that this is on the landscape. We have this more precision medicine for Alzheimer's disease, and we will see development of treatments like this for other neurodegenerative diseases within the next 2-3 years. There are things for the alpha-synucleinopathies like Parkinson's that are getting close to being available. So that more to come on that, and I'm sure we'll see lots more for Alzheimer's disease as well. There are a number of trials. So I wanted to end early, give lots of time for questions. Dr. Singer and Lori and I are happy to take any comments or questions. Thank you.
We also have virtual, so we're going to be getting questions from virtual.
Oh, yeah.
We have a microphone to bring back. Oh, yeah.
Okay, so I live in Southwest Harbor, that's where I have my patients. I have a handful of people that can't be seen by you guys because the waiting list is so long. So, I'm doing the labs, I'm doing the imaging, I'm doing, I do the slums actually, but I think it's the same as video, but anyway. And then they're going to other places and getting like a $3,500 evaluation by a private person, or we're doing speech therapy, which is great. She tells them we could try some things. I was told by my internal medicine guy that there's no point trying any of the medications. Put them all in sertraline, that sort of thing. We're talking 60 and 70-year-old men and women. And then, then we kind of put our hands up in the air and say, okay, well, hopefully you're safe and hopefully you're okay. Like some of them, they get to where they beat up their spouses and all that sort of stuff. But so far, I've gotten absolutely no response from any referral that I ever sent to the client. So it's not a question. I'm just like, what am I supposed to do? Can I have your guys' phone number so I can get my patients in to see you? That's it.
Yes, you can. Just email us directly. Yeah, I don't think so. Just email Justin or I directly, or Lori. Oh yeah, email her. So csinger@northernlight.org. We want to know when you have problems like that. As far as there was a lot in your question that in your comments that we need to address. One is the futility of prescribing medications for people with Alzheimer's disease, and I'm assuming we're talking about cholinesterase inhibitors and memantine, and we have a completely opposite perspective on that. Only 30% of people will show any kind of improvement, and that improvement may be very, very subtle. But 80% of people will at least stabilize for 10 to 12 months. And that's worthwhile. And even after 3 years in placebo-controlled trials, they're still ahead of where they would be. There has never been a negative trial with a cholinesterase inhibitor. These drugs are effective, but modestly effective, and not noticeably effective in everybody, because if a drug is slowing a rate of decline in function, it's not going to be noticeable as improvement, and the feedback will not be positive. But to go with the data, and the data say that this person is doing better than they would otherwise have done if they were not treated. You go with the data. They're risky drugs. You have to monitor people carefully. The cholinesterase inhibitors especially have side effects, but so does memantine. We're definitely in favor of treatment. Treating neuropsychiatric symptoms, that's a whole nother conversation. But again, we're available through the e-consult mechanism and through the monthly case conferences to help you. Our HRSA-funded grant, why we're here, is really to help with this situation and to ultimately improve access to us for the patients who really need to see us. And again, talk Carrie into staying here so we can improve our capacity.
I have a question, but it's definitely a personal question. So my biggest fear, my family knows this is Alzheimer's. So I say I've had cancer. I know it sounds horrible, but then Alzheimer's. So I'm learning through history, like my great grandma, they didn't know back then, but like she was, on the streets going through garbage can, like she was confused. Then my nanny just passed away of that. All of her sisters, like you talk about these biomarkers. I don't want to be the Band-Aid. I want to, like, are there like those biomarkers? If I wanted to be tested, is that possible? Like, is there something that I can do, like, to genetically see if where I'm at? It's listening to something. I know it sounds like there's something's coming, but I am curious.
Yeah, thank you. This question comes up a lot, and that's a tough one. We have to think ethically once, right? We see, and there's lots of examples in other specialties, but in the dementia world, there are a lot of dominantly inherited, fully penetrant mutations. So you have a gene, you're gonna get the disease. And you have to ask the question, is it going to be a good idea to know that ahead of time, right? And for some folks, we advocate that they don't because of who they are, because of their circumstances, because of their attitudes and anxiety, that information may be counterproductive for them if there's nothing that they can do to mitigate that risk or delay its onset. So knowing something's there before you can actually treat it can be dangerous. Right. Some people would like to be as proactive as they can, right, and are motivated by that information. They can plan better. They can look at that list of 15 preventable risk factors for Alzheimer's disease and check all those off, right, and then reduce their risk of getting that or delay the age of onset with those interventions. So those are conversations we have, and that's actually part of genetic counseling. And so sometimes it's helpful to know that ahead of time, and sometimes it's very counterproductive, and we certainly see that in families. So, in a personal case, of course, we'd be concerned about with multiple family members having it. And there are certainly research trials available that for folks that are pre-symptomatic, we're starting a pre-symptomatic clinical trial as well. But I think those are thoughtful discussions to have in consultation with a genetics counselor or a specialist on, is it helpful to know ahead of time if there's a gene mutation? Again, sometimes yes, sometimes no. Regarding biomarkers, we do not do biomarker assessment for somebody who's pre-symptomatic unless we're looking at a clinical trial, because there are no approved treatments. We're in that pre-treatment realm of which there's no intervention, that has evidence for changing things at that point. So that's a tough subject and one that comes up a lot. But something we have conversations on to try and plan for.
I've already I know there's stuff that's happening, but like you hear a lot about we're learning now like what plastic, the particles in the brain. So like everything might have plastic. It's really hard to take leftovers and like, I don't have any plastic in the house anymore. But have you seen like some of that? I didn't see anything up there on that, but I know there was some research done from the University of Rhode Island, I believe that.
Yeah, so
Repeat the question because the virtual people won't hear what you
yeah,
said.
so the question was, have we investigated or seen the impact of plastics and the risk for dementia? So this is I'm a little fatalistic, and I think we're destroying the world that we live in, and we're seeing examples of that now in our specialty. So if you look at Parkinson's in particular, we have really good examples. Other than age and other than genetics, toxins are the biggest risk factor for Parkinson's disease. It's been very well established that organic chemicals like pesticides and herbicides are causative for Parkinson's disease. and through a number of mechanisms. And microplastics, a colleague of mine just wrote a paper on this about presence of microplastics inhaled, present in in the olfactory bulb, and that induces misfolding of alpha-synuclein. Also, same thing in the gut. These certain particles of a certain size can actually cause these proteins to misfold, hyperphosphorylated, and are likely a big risk factor for neurodegenerative disease. So we're in big trouble as far as things go, and I mean, the data is early on this, right? A lot of especially microplastics and protein interactions, that's in the lab level. Really hard to do that in the clinical level because that's a rapidly moving target, and these diseases are 30 years long, and so you can't get good data on that until decades after it's too late. But certainly the lab data is concerning, especially at this point, evidence-wise in Parkinson's disease.
Quick follow-up comment. So we are doing a pre-symptomatic clinical trial right now, but you have to be right now, all the slots are filled for people under 65. So if you know somebody with a family history or who's concerned, who's actually over 65, but does not yet have symptoms, we're doing a trial where they can get screened with a plasma biomarker and then enter in, if it's positive, then they can enter into a trial with a subcutaneously administered anti-amyloid antibody. And there are some data that show that there's potential for anti-amyloid antibodies given early enough might be preventive. Also should tell you about MENA, our Healthy Brain Aging Registry. And as we have new studies or new initiatives in healthy brain aging and prevention, at least you'll find out about it if you register for MENA. It's on Julie, it's on one of the handouts. It's on the table, yeah. MENA, the Main Initiative for Neurologic Aging and Health, MENA. Isn't that a great acronym, huh?
Give you two more quick questions. I'll hold my question and just say a comment. I wanted to piggyback on the point about, or the idea that a medication may not be helpful. From a family caregiver standpoint, if you hold out a pajama top and the person recognizes an armhole as a place to put their arm, that's helpful. And so if the medication, you never know what function you're not losing.
Right. Good point, Martha. And these studies are not well designed to pick up on things like subtle things like that can help caregivers. And that's why when you look at outcome measures from caregivers in terms of functional sustaining function, the outcomes always seem to be a little better.
I'll piggyback one comment to this to address that same question. We have well-meaning providers pull our patients off of these medications, sometimes without our consent or permission. And what we see is people fall off a cliff functioning. They have been holding them stable, and then we're trying to reduce polypharmacy, or you hear from someone that, no, those don't actually work. And then they get stopped, and we see a sharp decline in functioning from what was being held steady by the medicines. So the data is clear. Again, what Dr. Singer said, there's been no negative trials for those medicines, and they help people hold steady. So don't believe what you hear.
I have some clarifying questions. I'm over here. Okay, what you had just said, the medications, are you talking about the amyloid ones, or are you talking about the cholinesterase inhibitors or the NMDA?
We're talking about the oral anti-cholinesterase inhibitors.
Wonderful. And so that's the Licaricept.
Yeah.
Are you suggesting, again, clarity, that is what we should do first in primary care?
Talk in the microphone.
Yeah,
Is it the
yeah,
virtual
thank
people?
you.
Yeah.
Yeah, sorry about that. Selectively, first of all, the person should have Alzheimer's disease, Parkinson's disease, or Lewy body disease, because they're not likely to help in other patients. Now, sometimes there's mixed pathology with, say, a vascular cognitive impairment patient who may have some Alzheimer's pathology and may show some response, but we just don't have as good a data for those people. So if you have a good diagnosis and they're at late MCI or early dementia stage, and there aren't other contraindications like bradycardia anorexia and so forth, then we would advocate their use, but you do have to monitor them for gastrointestinal and cardiac side effects.
Okay, and then the last piece I have is what information do you want in an e-consult to have the most comprehensive evaluation on your end?
Good question. Specifically on e-consults, that's not up and running yet. So the case conference is. So e-consults, you run into the whole like billing and records and release, and that is some logistics that haven't yet been ironed out. But our dementia case conference is up and running. Those are monthly. We have a case conference request form. I think it's on the tables.
Yeah.
If it's not, we have more at our booth. And so those are the things we're looking for. Essentially, we're asking that the algorithm has kind of been followed. This is standard of care workup in primary care. And if we haven't done the standard of care, then we're not in the position where we can have the answer about what it is. So we're not requesting anything more than what should already be done in the first place.
And just to follow up on that, if you're getting stuck, you know, if you're following the algorithm and you're getting stuck, or you come across an unexpected finding and you're not entirely confident on what to do, you know, reaching out and asking the question. But to Dr. Otis's point, that's one of the goals with the care pathway too, is to really give primary care providers a good structure for doing that solid evaluation. Because you know how it is when you're going up to date, or you look at the Alzheimer's Association, there's a lot of recommendations out there. We were talking about recently with Alzheimer's, they're recommending a homocysteine. You know, I haven't ordered a homocysteine in, I don't even know when. So, and that's, we talked a lot about that we really didn't think that was gonna be particularly useful. So really what you have, that care pathway on the table and what's going to be built into the EHR and then on the website, that's your foundation.
We have time for one more?
Yeah. Yeah, we go to 10 after, right? Yeah.
So my question bears to dealing with patients that have wonderful, well-meaning family members who are, you know, very desperately researching anyway, like or what have you. But I have several that don't have Alzheimer's. I have sent them to neuropsych. I have done imaging. They have had testing. And one of the really persistent questions from family members is, what is their diagnosis? And I get 3, 4, 5, it depends on how many places I'm sending them. Now I'm sending one to Cornell Wheel because they've got Dr. Lisa Mosconi, and so do I. Let's see what she says. Absolutely. But I have a patient with who survived sudden cardiac death twice. She is in her early 60s and she has an oxic brain injury, and I know she does. But it's not specifying to any portion of the brain, either visually or even when she does neuropsych testing. She's now completed 4 self-made batteries of tests. And she's just one in kind of a pool, but it's very frustrating. And I'm looking at the family members, and I know a lot of the wisdom now, even in treating such things as menopause, stop looking at the hormones, start looking at the functionality. The patient's been in speech language pathology, seeing somebody twice a week for functional work and list building and all that sort of stuff. It continues to decline at a pretty rapid rate. And the family and several families keep coming back to like, well, if we could pivot to this diagnosis. And I was like, I really feel like all the literature is surrounding removing these plaques in Alzheimer's, and it's not surrounding how we're going to treat the brain of a dementia patient. And so I'm wondering, like, am I reading in the wrong direction? What would you offer that family?
So first of all, wonderful case for case conference. You should definitely bring her to case conference. Second of all, if she's had an anoxic brain injury and she's really declining rapidly, something else is going on. Third of all, we should be able to look at those neuropsychological evaluations and figure out what are her weakest parts of her function and what are her well-preserved parts of her function, and design a cognitive habilitation program for her. As far as defining the what is likely a degenerative process in there, that's where biomarkers and other tests might come into being. But yeah, you need some help with that kind of complicated case, or bring her to case conference. Dr. Otis probably has another comment.
Yeah, I would say it's common to not have a unifying diagnosis. And we see that all the time, right? Cognitive impairment, the brain is impacted by so many different processes. Some of them, social and family dynamics and what their kids think of their cognitive impairment, right? And how much that gets highlighted or downplayed, right? So we most of our cases are multifactorial. Even if they have a disease, right? Most of those cases are multifactorial. You take an 85-year-old brain with Alzheimer's and they have Lewy body 2 and they have multiple types of vascular disease and they might have TDP-43. So the answer is it's always all the above, right? And teasing out what factors are contributing to what can be very difficult. And we have to tell patients that. We have to tell their families that there is no unifying diagnosis. It's a sum of all the parts. People are complex, their brains are complex, and lots of these factors interplay with one another. And they don't like that answer, but we have to help them get there, right? And this concept is true in any specialty in medicine, right? There's so many things that are multifactorial and you don't get a nice answer about what it is. And we have to help patients and families work through that and continue trying to function, with those deficits. The last piece is how neuropsychological testing works. Someone may have deficits and still be performing like within statistical norms, and that could still represent a drop in their functioning because these methods aren't perfect, right? We're evaluating, we're estimating their pre-morbid intelligence and functioning, and then we're comparing them to what the norms are. People can drop from their baseline and still be within normal limits on testing, but there has been a change that they notice or their family does, and it might have a functional impact. So those are things to consider, right? None of these are perfect metrics, imaging, biomarkers, neuropsychological assessment, or history. And so they all have to be taken in context with one another.
One other thing to address there. I think inherent in your question and another question is what to do after you've done a diagnostic assessment. We really haven't touched on the longitudinal care of these patients very well. So the e-consult might help with that. The case conference might help with that. And the website would definitely help with that once that's up and complete to give you guidance. Also, even though there's a wait list, we're trying, it's down now, sometimes 6 months, maybe. I don't know. Well, hopefully. But you can get patients into mood and memory clinic. Don't give up trying. Also, Julie wanted me to let you know that if you're going to present a patient to case conference, try to get their signed consent. And the reason why we want that, you're presenting de-identified data, but we need to look at their imaging, their brain imaging review during the case conference is essential. And so you have to get the signed consent form so that Dr. Otis can de-identify the brain imaging so we can see it during the conference. So that's that little step you have to take for the case conference. But otherwise, there will be the website, the e-consult, and then you can also just contact us directly now that we're close friends.
On the on the monthly case conference, just reach out to me and I'll go through all the steps with you and
And unfortunately, we're out of time, but Dr. Singer and Dr. Otis would be willing to hang around for a little bit. If people have specific questions, there are bag lunches in the vendor room. We come back at 1:10. Okay. All right, thank you.